Shifting now to the last session with our Dr. Islam Mohammad Shehata. Dr. Islam is an assistant lecturer of Anesthesia Department, Ain Shams, Cairo, Egypt, and he is a visiting scholarship in Wexner Medical Center, Ohio State University, Columbus, Ohio, USA, and he is the associate editor of Annals of Medicine journal. He has a master's degree of anesthesia and EDIAC. We are great honored. We have a great honor to welcome Dr. Islam, our colleague, and we hope all the progress for him in his career. And he will speak about the intracranial hypertension. And of course, he will speak about the role of the anesthesiologist in case of intracranial hypertension. So please, Dr. Islam, go ahead. Thank you so much.
Hello, everyone. Unfortunately, our lecture today is a little bit long, so I'm gonna start right now. I have no conflict of interest. Our lecture about the role of anesthesiologist in the management of intracranial hypertension. We are gonna start from the basics and go upstairs to the advanced management. We will start with the intracranial pressure, basics of it, monitoring of the intracranial pressure interoperatively, and finally the management, and trying to solve or answer the questions about every step in the management. The basics. Everyone know Monroe-Kelly hypothesis. It's a very important hypothesis, and there's one which described the intracranial pressure. They stated that intracranial pressure constitutes of the CSF and the blood volume and the brain parenchyma included in a semi-rigid box, which is the skull. So if we have, this is the normal intracranial pressure. When the intracranial pressure starts to increase, the defensive mechanism includes decrease the CSF production or increase the venous flow, then there is a point of decompensation. As we can see in this diagram, this is intracranial volume start to increase till a point of decompensation. Here, the intracranial pressure will stepwise decrease. We will know about 3 points from the basics. Point number one about the dynamics. This is very important to know that CSF, the flow is 0.3 ml per minute, while the cerebral blood flow is about 700 ml per minute. The volume of CSF is half the volume of the blood inside the brain. So if you decrease the CSF by tapping, you will decrease the intracranial pressure, but increasing the CSF will not cause the increase that we imagine. I mean that you need like acute or abrupt change in the CSF to increase the intracranial pressure. This is number one from the basics according to these numbers. This is my article about the venous component of the intracranial pressure. Everyone know this equation about the cerebral perfusion pressure. It equals mean arterial pressure minus the intracranial pressure and the central venous pressure. After many experiments about on the baboon type of monkeys, they omit the central venous pressure. So everyone knows that cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. But in this nice article we talked about, they found that by the transcranial Doppler, the venous flow is directly proportional to the intracranial pressure. When intracranial pressure increase, the physiology of our body increase the venous flow to hit it down. And they found that the venous blood is about 70% of the total volume and the 30% for the arterial blood. So it should be an important component of the intracranial pressure. up to they stated that the intracranial pressure is the function of the venous outflow. So I think we should bring it back to the equation. And this is a good point to know how to manage the fluids in case of intracranial pressure we face every day in trauma, in head tumor, or even infection. This is something ironically to know that if you have patient with intracranial hypertension and you have low MAP, what the first thing the anesthesiologist do? Push some fluids. If you push fluids here, you will increase the central venous pressure. Increasing the central venous pressure may hinder the venous outflow from the brain, so it may increase the intracranial pressure, and ironically may decrease the cerebral perfusion pressure. So it's not the solution to push fluids. The fluid infusion, and especially in traumatic brain injury, should be judgmental. How to do it in a correct manner? This is about the fluid therapy in intracranial hemorrhage. A very nice article from the current opinion of Anesthesiology. They found that to manage the fluid assessment in a case of intracranial hypertension, you should give fluids by fluid assessment. You should objectively, not subjectively, know if your patient needs fluids or not. How much fluids? Euvolemic. No more hypovolemia. Why? Because they found that hypovolemia is correlated with bad outcome. Which fluids? The isotonic crystalloids, balanced like plasminate or ringer acetate, no more than the normal saline. Normal saline, if you use it in like a long case of brain tumor resection, maybe 6 hours, maybe 7 hours, and use it as maintenance fluid, it causes hyperchloremic metabolic acidosis, and it is not benign condition. They recommended to avoid the hypotonic solution for sure because of the brain edema and the albumin, and I think for the same reason in sepsis. But as a rule, for everything nowadays in medicine, it's personalized. I mean, if you have patient with peripheral edema already, I think you can push a little bit albumin. There is no contraindication for that. So it's a personalized, more than standardized according to your patient. This is number 2 from the basics about the flow. Again, to the famous equation, cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. So which map should the anesthesiologist keep? They found that MAP more than 150 will disrupt the blood-brain barrier, so you shouldn't increase the patient blood pressure, especially during intubation and extubation. The standard MAP or the recommended value for MAP according to the European Brain Injury is more than 90 millimeter mercury. According to AAGPI, it will be more than 80 millimeter mercury. Why there is a discrepancy? Because the intracranial pressure level is about 20 millimeter mercury. So 90 millimeter mercury minus 20 millimeter mercury will be 70 millimeter mercury, and this is the recommended cerebral perfusion pressure, especially in traumatic brain injury, or 60 millimeter mercury. So there is no big deal here. You should keep the MAP 90 or 80, not less than 80 millimeter mercury, so you can keep the cerebral perfusion pressure more than 60 millimeter mercury. So number 3 here in the basics, your MAP shouldn't be so high, so hyperemia will increase the intracranial pressure, shouldn't be less than 80 millimeter mercury to avoid the cerebrovascular stroke. We mentioned that the intracranial pressure definition is that if it's increased than 20 millimeter mercury, but the new guidelines say that 22, not big deals. This is the normal values for the intracranial pressures in adult, children, and infant, and there is nice correlation between the values and the mental status. If you have your patient is confused, maybe arousable, it's more than 30, so it's definitely increased. It's definitely a case of intracranial hypertension. The role of an anesthesiologist is to identify the high-risk patient for increased intracranial pressure, This is the predictors, major criteria and minor criteria. You can check it, but for sake of time, I'm gonna explain this number 1 and 2 about if you have a CT brain. This is for our esteemed resident doctors. If you have a CT brain, how to find the signs of increased intracranial tension by compressed cistern and the midline shift. What are the cistern and how it's midline shift? This is, as we can see, obviously there is midline shift here. Another one here, there is no brain edema or not evident. You can compare this one and this one and this effacement all through the brain. The cistern, this is called supracellular cistern. This is ambient cistern, and this is the most important phasal cistern. As we can see here, there is no phasal cistern, so it's compressed, the sign of increased intracranial pressure. So if you have CT brain like that, yes, it's a case of increased intracranial tension. My question to the audience, is Cushing reflex a predictor of intracranial hypertension? I hope I can give 20 seconds for the answers. Is Cushing reflex hypertension, bradycardia, and irregular breathing is a predictor of intracranial hypertension? I said predictor. No, it's not a predictor. Why? Because the physiological mechanism, which in case of intracranial hypertension, is that when intracranial pressure increased, the sympathetic outflow will be increased, causing increased blood pressure, increased heart rate to increase the cerebral perfusion pressure. Then baroreceptor reflex comes into play. It will decrease the heart rate, trying to facing the increased blood pressure. Finally, or eventually, this will decrease the cerebral perfusion pressure. Decreased cerebral perfusion pressure will cause ischemia, affecting the respiratory center, and apnea occur. So if you had the patient with Cushing reflex, it's a very late sign of malignant intracranial hypertension, and it's a flag of emergency. It's not a patient going to develop intracranial tension. It's a very late sign. It's not the initial sign. If you have patient with increased intracranial pressure, as you can see in imaging by history, if you have blood pressure high and the heart rate high, yes, it's early. It's in the start of the game. But if you have Cushing reflex, it's a flag, or it's a sign of emergency, and you should push all your drugs to hit the intracranial tension down. What about monitoring of intracranial tension? Is every patient worthy to put lumbar drain to measure the CSF and managing according to it? There is the guidelines here. This is the indication of monitoring with very special indication for the traumatic brain injury according to the Brain Trauma Foundation. If you have a patient with traumatic brain injury more than 40 years and have light motor pushing decorticate or disrepate, and the systolic blood pressure less than 90, it's level to be able to put lumbar drain to measure the intracranial pressure and tap CSF as long as to keep the intracranial pressure less than 20 millimeter per. How to monitor is not our, for sake of time, I'm gonna skip it. So is it beneficial to put lumbar drain and measuring the intracranial pressure objectively? This is called the PEST trial, coming from Ecuador. It's called PEST intracranial pressure trial. It's multicentric, more than 300 patients. They found that, or comparing between monitoring the intracranial pressure with clinical, I mean the clinical status of the patient, the Glasgow Coma Scale, the pupil reaction, or imaging like CT brain, and objective monitoring of intracranial pressure by lumbar drain. They found that the same outcome. There is intracranial pressure not monitoring, not superior, but patient who had received the lumbar drain for intracranial pressure monitoring, they found they have like less ICU stay. So it's bigger than a figure. It's not about the lumbar drain alone. It's all not about the clinical or imaging alone. You should like have all that these multi-modalities together to interpret or to monitor the intracranial pressure and managing it in the correct manner. Why? Because if you have a patient with normal intracranial pressure, that not it doesn't prevent the secondary brain injury if your patient got hypoxic. If you have normal cerebral perfusion pressure by normal MAP more than 80, your intracranial pressure less than 20, the microvascular dysfunction from the trauma can't be excluded. So please, in your patient, do everything you can do to monitor objectively the intracranial pressure, clinically, the patient status, the imaging, and if you can put lumbar drain, you can, I think it's a good thing to do. Our management, I think it's like a photo to include all the upcoming questions about the management and the role of an anesthesiologist to manage the intracranial hypertension. We are gonna answer this question. The first one, which inhalation agent, which MAC, CO2, how low is too low? Should it always be the white drug? I mean, propofol, mannitol, and furosemide. We use it every day. Is it the formidable combination? What about the hypothermia and its cost-benefit ratio? And anemia, when to treat anemia in traumatic brain injury? And finally, about steroids. Does one drug fit all types of brain edema? Our first question about inhalation, which agent and which MAC? This is our inhalational agent, and this is called uncoupling, because you know, if you have high oxygen consumption, you should have high cerebral blood flow, but here isoflurane, desflurane, and sevoflurane cause increased level of blood flow and decrease the oxygen consumption or oxygen metabolism, and this is called uncoupling. So inhalation will increase the cerebral blood flow, increase the intracranial pressure. Can we do anything to attenuate this reflex? Yes, by the ventilation producing hypocapnia. If you hyperventilate, you will decrease the CO2. This can attenuate the increase in the cerebral blood flow. Should we do it? We will answer it in the next question. So this is our agent, isoflurane, desflurane, sevoflurane. Which MAC? This is nice study on the children, comparing between 0 MAC, 0.5 MAC, and 1 MAC. They found that the intracranial pressure, as you can see, it's dose dependent. By increasing the MAC, you will increase the intracranial pressure, as we can see here. And they in this study they did very nice thing, that they keep the level of end-tidal CO2 constant to avoid the effect of the hyperventilation on the effect of hyperventilation. We talk about there is like dose dependent increase of intracranial pressure with the MAC, and it's very important to know that when you increase the MAC or the concentration of any inhalational agent, you will increase the intracranial pressure, and in the same time you will decrease the mean arterial pressure by its vasodilatory effect. So you will decrease the cerebral perfusion pressure according to the equation we mentioned. Which agent is better? Desflurane may increase the intracranial pressure more than isoflurane, and the least one. So desflurane, the least effective is for sevoflurane according to this article. Now, CO2, how low is too low? We talked about the hyperventilation or hypocapnia, which attenuate the effect of the vasodilatory effect of the inhalational. So should we decrease the level or the level of CO2 or no? And how low is too low for CO2? As we can see here, the PaCO2 from 20 till 60 or 80 millimeter mercury, every 1 millimeter mercury change in CO2 will cause a change in cerebral blood flow by 2 to 4%. It's important to know that CO2 reactivity is time limited because the kidney will kick some bicarb, so the reactivity for CO2 and its effect on cerebral blood flow is limited for about 6 hours. If during ventilation, during sedation, during the pre-intubation ventilation. I mean, in the first minutes of anesthesia, when you support your patient to just before intubation, I mean, you may cause hypopnea. Hypopnea may will increase the CO2, cause hypercapnia. This hypercapnia will cause vasodilatation and will cause what's called the steal phenomena. Inversely, hypocapnia will cause inverse steal. Inverse steal means that if you have hypocapnia cause vasoconstriction, it will shift the blood from normal tissue to injured tissue. But this effect is not on the brain only, it will be also on the heart, on the coronaries, and I think it's like a disadvantage. So CO2, every 1 millimeter change will change the cerebral blood flow high or low by 2 to 4%. Some mathematics, we said that CO2 more than 44 millimeter mercury or less than 35 millimeter mercury, every 1 millimeter, 1 milli mercury change will cause a change in cerebral blood flow by 3%. So if you hit the CO2 from 35 to 20 millimeter mercury, you will decrease the cerebral blood flow. The difference is about 15 millimeter mercury. 15 multiplied by 3 by 40%. So hypocapnia level 25 or 20 millimeter mercury would decrease the cerebral, will have the cerebral blood flow down. So it should decrease the cerebral ischemia. And the most important that it's not about the cerebral ischemia. How all this decrease or all this value down will affect the intracranial pressure you want to decrease. They found that the PaCO2 affected the arterial system more than the venous system. We mentioned that in the basics, venous system and the capillaries more than 70% of the total blood volume, and the arterial system is just 30%. So if you divided this 40 or 50% by 3, so it's about 30, the intracranial pressure would decrease only 10%. So to remove just this metal, you destruct the whole tissue. You will cause secondary brain injury by decreasing the CO2 to such level. Number 2, what about the hyperventilation? We talked about that it will decrease the cerebral blood flow, causing cerebral ischemia, and in the same time, it will decrease the intracranial pressure just 8 to 10%, not a worthy value. If you cause hyperventilation may induce hypoxia in such situation. How? Hyperventilation or hypocapnia will shift the oxygen dissociation curve to the left, so no more oxygen be released. It will decrease the cerebral blood flow. It's part of ischemia. They found that it increased the excitatory amino acids like NMDA and the glutamate, which will increase the cerebral metabolic rate of oxygen. So by definition of ischemia or definition of stroke, which is no balance between or lack of balance between the demand and the supply, hyperventilation may cause like local brain hypoxia. And they found that by measuring the jugular venous oxygen pressure. The second part of secondary brain injury due to hyperventilation. So the guidelines of the Brain Trauma Foundation, level 2B evidence, stated that no prophylactic hyperventilation, no profound hypocapnia, 25 millimeter mercury, no hyperventilation, especially in the first days after trauma. And if necessary, you want to hyperventilate to get the intracranial pressure down, please measure the oxygen tension to avoid the hyperventilation-induced hypoxia. Give me a number. PaCO2 should be maintained between 31 to 34 millimeter mercury, not less than that. Another important point to be answered about the ventilation is the positive and expiratory pressure. Put PEEP or no PEEP. Your patient has to have, if you put a high PEEP, it will increase the intracranial pressure. Yes, but you should know that the effect of PEEP is not always. Is the net stable, Dr. Saad? Hello?
This is okay.
Yes, yes, everything is okay. Yes, please. Continue, Dr. Islam. Yes, we hear you.
You should put PEEP, and you should know that the effect of the PEEP or in increasing the intracranial pressure is not for all patients. If you have a healthy patient, yes, the effect of PEEP on increased intracranial pressure will be evident if your lung compliance is good. So the effect, who needs PEEP? Patients with low lung compliance. If you have a patient with any like ARDS, like pulmonary edema, or any restrictive lung pathology, this patient needs PEEP. In this case, the effect of PEEP or on intracranial pressure will not be the same as other patients, because the effect of PEEP or on intracranial pressure would be high only in case of normal lung compliance. And for sure, if your patient has like decreased cerebral compliance, this patient come to the OR with giant tumor or with a severe hemorrhage compressing the whole brain. In this case, yes, you can put the PEEP at lowest level. But if you have patient who needs PEEP, like restricted lung disease, put PEEP, it will not affect the intracranial pressure as you imagine. Back to anesthesia. Should it always be propofol? If we use propofol for, this is the effect of propofol. It can decrease the intracranial pressure, better hemodynamics, neuroprotective mechanism. But I think dexamethasone worth it to try. We should try it in the like in sedation or maintenance in patients with craniotomy. Why? Because the advantages. This is the advantage of dexamethasone. The neuroprotective effect, it limits the hypercapnia and the hypoxia induced cerebral vasodilatation. And for sure, we said that you shouldn't let the MAP increase or systolic blood pressure increase during intubation and the extubation. They found that dexamethasone inhibit the ischemia-induced norepinephrine release and decrease the norepinephrine during emergence from anesthesia. So it's worth to try. And they talk about dexamethasone since 1991. It's not a new drug to be used in neuroanesthesia. This is some papers about the intraoperative switch from propofol to dexamethasone. As we can see in cervical fusion, they found that it's a better neurological examination with dexamethasone rather than the propofol. In function neurosurgery, they found it's a better testing during using dexamethasone rather than propofol. And in carotid endarterectomy, they found that patients who were running on dexamethasone have like this agitation and less respiratory depression than propofol. So all of these are comparative studies. But dexamethasone will decrease the intracranial pressure? No. In the human study, they found that there is no effect on lumbar CSF pressure in patients of transsphenoidal pituitary tumor. But again, if you put your patient on dexamethasone, it will decrease the sympathetic outflow. It will decrease the pressure response during intubation and extubation, which have like deleterious effect on the intracranial pressure. So I think we can say dexamethasone relatively decrease the intracranial pressure by preventing the abrupt increase in intracranial pressure during intubation and extubation. Any comment about the safety? Yes, they found that in patients with traumatic brain injury, dexamethasone may cause hypotension, so they recommended no loading dose. Fast shot about anesthesia: do not use ketamine in patients with increased intracranial hypertension, but because of the increasing the blood pressure, increasing the intracranial pressure, but you can blunt its effect by propofol. Do not use acetylcholine because of increasing intracranial pressure, but you can blunt its effect by pre-treatment with non-toprazole relaxant. It's not preferred to use histamine release agent like atracurium, which increase the intracranial pressure, but they found that there is no aggressive effect. And if you didn't push it rapid, if you dilute it, there is no histamine release. And I think the whole percentage is about 3%. It's not a number, but they confirmed that do not use nitroglycerin to decrease the blood pressure in patients with increased intracranial pressure, because it will increase it. You can use esmolol because it has no effect on intracranial pressure. And they found that fentanyl and the diazepam before induction will decrease the pressure response for sure, and will prevent the increased intracranial pressure during during intubation and during intubation. Our third question is about mannitol and furosemide. We use it every day. Is it the formidable combination? Mannitol, there is no other solution. This is we'll start with alternative. This is article about glycerol infusion versus mannitol for cerebral edema. They found that they have same effectiveness with lower acute kidney injury in case of glycerol. Another one is the hypertonic saline, but before presenting the hypertonic saline, it's another question for the audience. What is the most commonly encountered electrolyte disorder in neurological affected patient, like traumatic brain injury or anything?
Hyponatremia.
Yes, thanks, sir. The most commonly encountered electrolyte disorder is hyponatremia. In hospitalized patient, the percentage is 20%. In a neurosurgical patient, the percentage is 50%, and its effect on mortality, if it's less than 120 milliequivalent, it increases the mortality with 25%. You can imagine. So your patient by default has like 50% 1-to-1 ratio to have hyponatremia. Mannitol causes hyponatremia initially. So mannitol causes hyponatremia initially. It can cause hyponatremia. The Brain Trauma Foundation recommended mannitol at 2007. The Brain Trauma Foundation every 10 years, they recommend mannitol at 2007. But at 2017, they stated that there is increasing, 5 years ago, they stated that there is increased use of hypertonic saline as alternative, but it's insufficient evidence till now. So can we use hypertonic? This is, I'm gonna present or show some papers comparing the hypertonic saline for mannitol. This is very nice one from a neurosurgery at 2020, a couple of years ago. They comparing between the hypertonic saline and the mannitol, according to increase the intracranial, the effect of high intracranial pressure and low cerebral perfusion pressure. How mannitol will decrease the cerebral perfusion pressure by hypovolemia. They found they comparing the total number of days. So this is the total number and the percentage of days comparing between the effect to reduce the intracranial pressure and the effect on cerebral perfusion pressure. They found that hypertonic saline is better, especially in refractory intracranial hypertension. It's more efficient. It's more effective than the mannitol. And if your patient has low mean arterial blood pressure, please do not use mannitol because it will decrease it a lot, and you can use hypertonic saline. So I think after 10 years at 2027, I think the Brain Trauma Foundation will state that hypertonic saline may be the default. Another one comparative study between bolus dose of hypertonic saline, mannitol and the glycerol, they stated that hypertonic saline is better or the best among the 3 alternatives. But we use mannitol. So for our esteemed resident doctors, if you use mannitol, you can the dose is 0.1 to 1 gram per kg over 10 to 15 minutes. Please do not use mannitol if you have like high serum osmolarity, more than 320, and if your patient has acute kidney injury. If you want to try the hypertonic saline, you should push it in the center venous line. The dose is 75 ml per hour, and you should follow for sure the sodium. And do not use hypertonic saline if your sodium is more than 160 millimole per liter. Another question about the hypothermia was the cost-benefit ratio. The hypothermia, if you push your patient temperature between 32 to 34 Celsius, it will reduce the intracranial pressure with less incidence of arrhythmia as long as you keep it more than 30 degrees of Celsius. But they stated in this guidelines about the hypothermia for increased intracranial pressure, they stated that no role for prophylactic hypothermia. So you should use it if you have a definite case of malignant intracranial hypertension. It should be reserved for refractory intracranial hypertension. So after pushing all your equipment, just reserve the hypothermia as the last resource. And the most important, during rewarming, you shouldn't start rewarming before till the intracranial pressure be less than 20 millimeter mercury. And you should be very gradual because rewarming will cause a rebound increase of intracranial tension for sure. How? By rewarming, increasing the temperature 0.1 to 0.25 Celsius per hour. So please do not use hypothermia except in refractory intracranial hypertension, and during rewarming, be gradual. And this is the references about the hypothermia. Anemia, when to treat anemia in patients with traumatic brain injury, it's very important. And this is very nice slide. They put standards to treat anemia and traumatic brain injury depending on neurological examination, jugular venous oxygen tension, and the lactate. So they assess the patient globally and the oxygen tension of the brain, which reflect the perfusion for sure, and the cellular level in picture of lactate. They stated that your transfusion threshold either 7 or 10 grams per deciliter. I will push back the RBCs patients with low hemoglobin, lower than 7 grams, if the patient is awake and there is no brain hypoxia or high lactate. So this patient can tolerate hemoglobin of 7 grams per deciliter. If your patient has like poor neurological status, and there is low jugular venous oxygen tension or high lactate, so you should keep the hemoglobin about 10 grams per deciliter. I hope it's clear. Our final question to be answered is about steroids. Should I push steroids for every patient with intracranial hypertension? This article answered that there are 4 types of edema may be associated in neurological affected patient. The most important, the steroid is the mainstay treatment in one case, the vasogenic edema. Vasogenic edema, which is associated with tumor and the infection. Why? Because the pathology is increased the permeability of blood-brain barrier. So the dexamethasone, you can stabilize the blood-brain barrier. We can give it in a maximum dose of 16 milligram per day. Some go to 24, but the literature says that maximum dose is 16 milligram per day. So in case of tumor and infection, not in traumatic brain injury. Why? Because they found that using steroids in traumatic brain injury, there is no decrease of intracranial pressure or even mortality. Up to the Brain Trauma Foundation stated that we shouldn't use, it's contraindication to use high dose of methylprednisolone. It will not do anything, but it will increase the mortality. So these were our questions. I hope that we answered. And then final, we can stated that years of care in patients with increased intracranial hypertension, head up can have a role. If you have a patient with increased intracranial hypertension and indicated to monitor it, you can put a drain and tap the CSF to maintain the intracranial pressure less than 20 millimeter mercury. As regards the fluids, your patient should be euvolemic, and you should use isotonic balanced solutions. You should keep the mean arterial blood pressure more than 80 millimeter mercury, CO2 not less than 31 millimeter mercury. you should try hypertonic saline, especially if your patient has low mean arterial blood pressure, and for sure if there is hyponatremia. Hypothermia only for refractory or malignant intracranial hypertension. Hemoglobin should be kept more than 10 grams per deciliter in poor grade patient. And finally, no steroids for traumatic brain injury. Thank you, and sorry for interruption, but you know the electricity is down, and I think I cannot do something for sites.
Thank you so much, Dr. Islam, for this very nice lectures. I think today we spend nice time with the neuro session, and it was a heavy meal for the neuro session. But Dr. Islam, we have some question, but before this question, I think you spoke about the management of intracranial hypertension, and I think I'm still confused about. You were speaking about the role of intensivists in the intracranial hypertension, or the role of the anesthesiologist if he was confronted with a case of intracranial hypertension and he's going to anesthetize this case.
Why did you say, sir, for intensivist? I think all the lecture about anesthesiologist, we use furosemide, we use mannitol, we use ventilation during anesthesia, we use steroids, we use fluids. So I think it's tailored for anesthesia. So when I talked about the monitoring, I said no, it's not for anesthesia, so I skip it.
So this, you mean that when we are confronted with intracranial hypertension and we are going to anesthetize a patient with intracranial hypertension, am I right?
Yes, yes, yes.
Do you think that intracranial hypertension is an elective case or an emergency case?
As we can say, depending on the patient, the neurological status of the patient, if it's confused, for sure it's emergency. According to the pathology, if you have a patient of hydrocephalus, not that the patient like bleeder from arterial like MCA or nothing else. So it's depending about the general condition of the patient, about the pathology, about and they for sure after discussing the case with the neurosurgeon. So it may be elective, it may be emergent. If you have a patient with tumor and the tumor for a couple of months not increased, but we wanted to remove it like now, it's not. It will be the same case as a glioma with a rapid shift, rapid deterioration, and the motor deficit.
Thank you so much. There is one question about what about the anticoagulant use in patient with TBI?
This for intensivist.
Okay.
Yeah.
So
Hello,
this
sir.
is the role of intensivist.
Yes.
Okay. Any questions from the audience?
Sir, one question from me. I'm Dr. Simanja from India. Just
Hey,
tell me, suppose the patient is having hyponatremia, sodium less than 120, patient is symptomatic with the raised ICP. You are giving bolus hypertonic saline. So what is the risk of developing cerebral pontine myelinosis?
Yes, you know, it's not about the loading dose. Hypertonic saline, especially even in case of, it's about the level. If your patient is has like deleterious neurological status or poor grade and there is hyponatremia, it's recommended to give a bolus. Cerebral pontine myelinosis will happen if you increase the sodium abruptly, if you increase it directly, if you increase it higher. Bolus dose will not increase it in for a level that cause cerebral pontine myelinosis, and it's in the literature. Literature talked about the bolus dose in case of comatose patient. If you have hyponatremia and your patient not conscious, is not conscious, it's a recommendation for giving about mid-mil of hypertonic saline 3%, because it's emergency if the cause is hyponatremia. So the cerebral pontine myelinosis will not happen from a bolus dose if the sodium level less than 120 and the patient conscious level is not stable. If you have patient of as we can see, the chronic patients, the elderly patient, he came to the ER with sodium about 125 and he is very conscious. So I think there is no rule for bolus. But the bolus, which I mentioned, like 75 mil per hour, it's maintenance dose. So it's not bolus as we can imagine. We will not push the hypertonic. I said the dose is 70 mil per hour. So it's not bolus, it's over 1 hour.
So my second question and last question. If the patient who is having head injury with rare features of rare ICP, and patient is also in shock, probably some intra-abdominal injury, so whether you would like to induce the patient with ketamine?
Again, if your patient, what and what, please?
Patient is having a head injury with
Yes.
intra-abdominal injury and patient is in shock, whether you will induce the patient with ketamine?
You mean patient with hypertension and head injury?
Yes.
Yeah. Every time I discuss this lecture with my resident, I tell them the first priority to the blood pressure. I'm gonna push ketamine because ketamine will increase the intracranial pressure temporarily. It's a very short acting agent. But if I pushed propofol or anything else, I will hit the mean arterial pressure down. So not only the brain perfusion, but the heart, but everything. So the patient will be crashed, and this is the definition of secondary brain injury. So any patient with high intracranial pressure and low blood pressure, for sure, I'm gonna start with ketamine without any propofol. What about the intracranial pressure? I'm gonna hit it with many other weapons, like even if I did like temporary hyperventilation or push some diuretics, but the role of anesthesiologist is to prevent the secondary brain injury, especially the post-induction hypertension. So I'm gonna push ketamine, and I will feel very relaxed.
Thanks.
Any more questions? Okay. At the end of this webinar, and on behalf of my dear leader, Professor Saad Mahdi, he's the leader of the MEGA course, I'd like to thank and appreciate the efforts that had been done by all the speakers, Dr. Amr, Dr. Barbara, and Dr. Islam, for these nice lectures. And I hope all the success and the progress for all of the audiences, and I hope to meet again. And I'd like to announce that the next week will be MCQ ICU interactive session, and on 6th of November, the webinar will be on the perioperative safety. I thank you so much for all the attendees, and goodbye and good night. Thank you so much.